All right, guys, welcome back to Underground Science. In this video, we're going to be talking about familial Mediterranean fever. Okay, familial Mediterranean fever is actually autosomal recessive, so you need two copies of the mutated gene in order to get this disease. Where is this gene located on? It's on chromosome 16, and the gene is the MEFV gene, okay, specifically. Again, it's on chromosome 16, and this disease is autosomal recessive. So the MEFV gene from your mother has to be mutated, and the MEFV gene from your father has to be mutated. Okay, so you need both copies of this gene to be mutated in order to have it. If this gene is mutated, you have dysfunctional pyrin. So actually this gene, right? If you make this gene undergo transcription and translation, it codes for a protein called pyrin. Pyrin prevents excessive activation of neutrophils and excessive release of interleukin 1 beta. If you have a mutated MEFV gene, you don't have a functional pyrin protein, so you're going to have excessive activation of neutrophils and excessive production and release of interleukin 1 beta. Okay, so let's see what that's going to lead to. Of course, if you have excessive release of cytokines like interleukin 1 beta, that can go to your hypothalamus and trigger a fever, right? So the fever part makes sense. Also, in familial Mediterranean fever, what happens is all this inflammation, right, especially the excessive neutrophil activation, can lead to serositis. So what this means is the neutrophils, right, can start to attack serosal membranes. Now, what are those membranes? It can attack your peritoneum, okay, so that can lead to peritonitis. So this will lead to peritonitis. If I can spell this, peritonitis. If these neutrophils attack your pleura, right, of your lungs, this can lead to pleuritis. If these neutrophils attack your pericardium, right, the layer that surrounds your heart, the covering of your heart, this can lead to pericarditis. And lastly, if the neutrophils attack your synovium, this can lead to arthritis. Okay. Now, it's important to know that familial Mediterranean fever, I'll just write it right here, lasts around 12 to 72 hours. Okay, so that's important to know. So the these attacks last 12 to 72 hours, and then they actually resolve completely. Okay, but how do these attacks even happen? Right? What's the triggers? What are the triggers? So certain triggers can be things like infection, right? Or emotional stress, anything that basically any stressor basically, right, can be a trigger to this neutrophil activation and interleukin 1 beta release. Now, if this happens chronically, right, obviously you're going to have chronic inflammation. And with chronic inflammation, you have the risk of secondary amyloidosis. So what that is with chronic inflammation, you start to secrete acute phase reactant molecules, right? One of those being serum amyloid A, or SAA. SAA can actually lead to AA amyloid, okay? So AA can deposit as amyloid fibrils, right? So amyloid fibrils, okay? And the most common place being, as we know, your kidneys, which can lead to amyloid nephropathy and cause nephrotic syndrome, which we will cover when we talk about nephrotic and nephritic syndromes in our renal playlist. Okay, so you're going to have that proteinuria greater than 3.5 grams a day, and so on. Okay, so obviously this is not good for your kidneys, and this is what. So SAA and AA involvement is secondary amyloidosis. Okay, remember primary amyloidosis is relating to light chain amyloid, okay, which is seen in multiple myeloma and certain plasma cell dyscrasias, which we'll talk about later also. Okay, so this is secondary amyloidosis. All right, so that's the relationship between familial Mediterranean fever and chronic inflammation. If this happens over and over, you're going to have chronic inflammation. You're going to have increases in acute phase reaction proteins like SAA or serum amyloid A, which can definitely lead to amyloid fibril deposition, right? AA, and that can deposit in multiple organs, one of those organs being your kidneys, right? Which can lead to nephrotic syndrome. And if it progresses further, renal failure. Okay, so it's all due to the mutation in your MEFV gene, which leads to a dysfunctional pyrin. So you have a dysfunctional pyrin, you have excessive activation of neutrophils and excessive release of interleukin 1 beta. Those two things contribute to these attacks. All right. And where do the neutrophils attack? It attacks your serosal surfaces. Like what? Like your peritoneum, leading to peritonitis, like your pleura, leading to pleuritis, like your pericardium, leading to pericarditis, and like your synovium, leading to arthritis. Okay. So knowing it attacks those, right? So what we can understand from that is if we just skip the treatment for now, right, we'll come back to that. If you get if the neutrophils get excessively activated, we said you're going to have fever, right? But something to know is it's going to be a sudden high fever. Okay, it's going to be a sudden, underline that, sudden high fever with no clear infection. Okay, no infection. So if you see recurrent sudden high fevers, no infections, especially remember the triggers, right? Especially after the triggers, which is what? Like exercise or a certain stressor like an infection after exercise or other stressors, right? So if there's some minor stressor or exercise or emotional stress, then sudden high fever develops. There's no infection, right? And then you also see symptoms of serositis. So those being, as we've discussed, peritonitis, right? So you would see peritonitis, which would show symptoms of obviously you would see abdominal pain, right? So severe abdominal pain, and it can also mimic appendicitis. So that's something to keep in mind. So right lower quadrant tenderness, right? So appendicitis, and I'm going to write down mimic because it's not actually appendicitis, right? So it's going to mimic appendicitis. And then, of course, we said these neutrophils can attack your other serosal membranes like your pleura. So if you get pleuritis, obviously there you can have pleuritic chest pain and dyspnea, right? Because the pleura lines your lungs. And if you have inflammation of that, of course, it's going to hurt when you breathe. So you're going to have pleuritic chest pain and shortness of breath, are also called dyspnea. And of course, another serosal membrane would be your pericardium. If your pericardium gets inflamed, you can have pericarditis. And symptoms for that would be obviously chest pain, right? Because that's the covering that surrounds your heart. So if that gets inflamed, of course, you can have chest pain. You may have pericardial effusions, right? And then, of course, if these neutrophils get excessively activated and attack your synovium, you can get arthritis. And then, of course, that can affect, any joint like your knees, ankles, or hips. So we'll just write knees, for example, right? So of course you can get joint pain and swelling. But something to know is that this is going to be non-erosive. Okay, something that if you compare that to something like rheumatoid arthritis, which is erosive. Okay. So yeah, those are the symptoms that we should know based on what serosal membrane the neutrophils attack. Of course, we talked about if you do a blood test, you're going to see increased inflammatory markers like what? Like your erythrocyte sedimentation rate is going to be elevated, your CRP is going to be elevated, you'll have elevated serum amyloid, right? And you're also serum amyloid A protein. And then something that that you will find is no autoantibodies, right? Because other autoimmune diseases, like, for example, lupus or rheumatoid arthritis, you may see autoimmune antibodies or autoantibodies, I should say. But in familial Mediterranean fever, you would not see any autoantibodies, just inflammatory markers. And of course, you would see increased neutrophil count, so neutrophilic leukocytosis, okay, because you're having excessive activation of your neutrophils. So, knowing all that, if we just cover the last thing, which is treatment, we would want something that inhibits neutrophils, right? Because that's the main culprit, the neutrophils, in terms of attacking our serosal membranes. So the thought is that colchicine, what it actually does is it reduces neutrophil activation and chemotaxis, so that reduces inflammation. But another thought is that it reduces or it inhibits, right? So I should say inhibits your microtubule formation. Microtubule formation in your neutrophils, right? So if your neutrophils can't really polymerize microtubules, then that's gonna not activate your neutrophils, right? Because microtubules are important for cell function. So if your neutrophils can't form microtubules, can't polymerize them, then of course that's gonna prevent neutrophil activation. Okay, so that's the thought behind colchicine's mechanism of action. So if you give that, that's obviously going to help because you reduce the activation of neutrophils, therefore reducing the attacks on your serosal membranes. Next, you can give interleukin 1 inhibitors, of course, because remember pyrin, right? The mutation in the MEFV gene leads to dysfunctional pyrin, which leads to excessive release of interleukin 1, which also contributes to the inflammatory attacks. So if you give interleukin 1 inhibitors, then you can therefore reduce interleukin 1 production and reduce inflammatory attacks on your serosal membranes. All right, so that's basically familial Mediterranean fever. I hope this made sense and wasn't too confusing, and I hope you guys learned a little bit. Thank you for watching, and I hope to see you guys in my future videos.